All right, so we're recording. Allison, thank you so much for joining me. I'm going through this. You are the first person I've ever done this with, so I appreciate um, your willingness to help us through this very difficult topic. Mental health issues impact a huge percentage of our cases. I don't know the exact number, but I would say at least 70 to 75%. And so I wanted to just take a minute, go through the different types of the approaches towards mental health issues, and then maybe give a little um, explanation as to why a kiddo might be intersecting with that modality. So I will turn it over to you and let you take it from here.
Okay, awesome. I'm Allison Dinkin. I am a former CASA and am a mental health professional in the community. I am currently the mental health coordinator for Adams County School District 14 and provide trainings and support to CASA because they have a special place in my heart and didn't want to quite let go after I ended my last case. So I am thrilled to be able to provide some mental health information about different modalities to help provide a basic level of understanding of what kinds of mental health support kiddos may be needing that have CASA support. So just kind of I'm just going to go through some of the different bullet points that CASA has identified. So the first one is medication treatment and psychopharmacology. So studies show that for some mental health issues, medication is needed in addition to psychotherapy to help improve symptoms. Though most of these medications are prescribed by a psychiatric provider, i.e. a psychiatrist or a psychiatric nurse practitioner, many primary care physicians will prescribe some medications at some doses, depending on the medication and kind of what's going on with the individual. Psychiatric medications work to alleviate chemical imbalances in the brain. And because this is a really delicate process, these medications don't work right away. It's not like an antibiotic where you take it, you finish the course, and you feel all better. Oftentimes it can take 6 to 8 weeks to see if a medication will be helpful. And it is never recommended to abruptly stop a psychiatric medication because of that, due to some of the side effects. So it may be that a kid says, well, they put me on this med and it's not working. Well, how long have you been on it? 3 days. Okay, well, we need to take a little bit more time to see, is this the right dose? Is this helping or not? So at times, there continues to be a stigma around psychiatric medications, which makes some individuals unsure if they need them. For a lot of kids, they do need this extra support, this extra chemical to help. It's almost as if the individual had diabetes and they need the medication. So for a lot of not only kids but adults, they need that supplement. And so, as you are advocating for the kid, is it in their best interest to be on this medication? Is it helpful? Are they on too many medications? Are the medications kind of numbing their feelings, or is it a helpful kind of in addition to, so that they can process some of the things that are going on? Are definitely questions to keep in mind. So I'm going to go over some common psychiatric medications. So the first one is what they call anti-anxiety agents. So these are often taken for panic attacks due to their short half-life, meaning they take effect rather quickly. So common names include Xanax, Valium. These are referred to as benzodiazepines. Kids are not prescribed these medications. Typically, this is more of an adult thing. However, there are some individuals that do abuse these medications. They can be addictive. And so you may hear the name if a parent is struggling with substance abuse, that they may have been abusing those. There are some teenagers as well that dabble in some of those medications because they do produce a rather calming effect rather quickly. And then antidepressants. So there's two kinds that are most commonly prescribed now. So SNRIs, which are serotonin, norepinephrine reuptake inhibitors. The fancy name for serotonin and norepinephrine are the chemical norepinephrine. I can never say that word. Are the chemicals that kind of the synapses are working with Common names for those are Zoloft and Lexapro, and then there are SSRIs, which are selective serotonin reuptake inhibitor. So the common theme there is serotonin is commonly referred to as a happy chemical along with dopamine. So those that are struggling with depression are often lacking in those chemicals, or they're not firing in the maximum effect. So SSRI common ones are Effexor and Cymbalta. These can be prescribed for anti-anxiety disorders as well. Antipsychotics, so these are broken down into typical and atypical. So these medications are often needed for individuals struggling with psychosis, namely which are hallucinations or delusions, or seeing or hearing things that are not there. Many times individuals may need these medications to manage what's called an SPMI, or a severe and persistent mental illness, such as schizophrenia. So common names include Haldol, Zyprexa, and Risperdal. Typically, individuals have what's called their first episode of psychosis, or their first psychotic break, quote unquote. It happens in late teenage years, early adult years. If individuals that are younger are seeing or hearing things or having hallucinations or delusions, sometimes it can be due to trauma. It's a common symptom of PTSD. So that is very normal, or they could be having early onset psychosis. So some of those medications may be seen more in parents that might be struggling with schizophrenia or another severe and persistent mental illness. And those medications can have some side effects. And so a lot of people don't want to take them, or the voices can be really comforting. So there may be some, dependency and neglect stuff if parents are not attending to their own mental health issues. Mood stabilizers. So these medications are often used to treat individuals who are suffering with a mood imbalance, such as bipolar disorder, used to be called manic depressive disorder. So like antipsychotics, many individuals may need to use these medications long-term to help manage their symptoms. Common names include lithium and Depakote, and these also can have some physical side effects. So it's important to make sure that they're being managed not only by a psychiatric provider, but they're seeing a primary care physician as well to alleviate some of those symptoms. Stimulants, so these are used to help individuals who are struggling with attention deficit hyperactivity disorder. And so they increase the dopamine and norepinephrine in the brain. Common names include Vyvanse and Adderall. This is a commonly prescribed area for kiddos. And ADHD can often mimic symptoms of other mental health disorders. It can look like anxiety, it can look like PTSD. And to be mindful, how much the kids are taking of these medications and when they're taking them, if they only need it for school, or, what are we doing then on the weekends? Or is this kind of an everyday thing? I think also having a conversation when they're seeing a therapist, is this true ADHD, or is this a reaction to the trauma and stressors going on in their lives? And how can we manage that? If we need medication, that's okay, but is this really ADHD, and are we just medicating kind of the situation? So another form of medication treatment is specific to substance abuse and includes the prescription of medications to help curb cravings for drugs or alcohol, as well as the side effects from withdrawing from those substances. So common names are methadone, Suboxone, Antabuse. There are some medications that if an individual is abusing a substance and they take that medication, it can make them sick. Other ones that help curb the cravings. Methadone and Suboxone are used to kind of withdraw over time. Methadone in particular, parents may be going to a methadone clinic, which is helping them kind of manage those cravings and withdrawal symptoms so that they are less likely to relapse and reuse those substances. There are clinics throughout Colorado. And so, I think for a lot of kiddos, trying therapy first is important. We don't always kind of want, and I think there's a fear of medicating the problem and not addressing the problem. And so most guardian ad litems, most providers are going to want to try therapy first. And then if that is not working, or the symptoms are so severe that they're not able to function, they're not able to attend school, complete their schoolwork, be, an active participant in their daily lives, then medication is kind of a next step for a lot of people. There are some kids that if they have been involved in the system for a while and have quite a bit of trauma and mental health stuff, where medication is needed right away. So I think as you advocate for the youth that you're working with, really kind of as you're gathering information from other people and the youth, depending on their age, if appropriate, really asking, is this the best course right now? Is this what we need? And if it is what the child needs, really supporting. And if you have any own kind of personal judgments around mental health medications, to kind of what's best for the kid and how can I place that in a different area. Other questions about medications?
That was great. Very thorough. Thank you so much.
Awesome. So the next category is behavior therapy, which is a really broad term. So it can be broken down under a variety of different areas, but loosely kind of refers to the psychology to augment or to change behavior. There's kind of strict behaviorism, which I'm going to talk about, and then kind of behavior therapy, which focuses more on changing the behavior through a therapeutic lens. So behavior therapy pays close attention to the relationship between our problems, our behaviors, and our thoughts. So kind of classical behavior therapy, or behavior theory, or behavior treatments involve the promotion of desirable behaviors, so increasing the behaviors we want and reducing unwanted behaviors and decreasing the behaviors we don't want. So positive, and negative reinforcement, as well as punishments, are the hallmarks of a classic behavior model. An example of positive reinforcement is giving Johnny a sticker every time he says please. That we want to do that. We want to reinforce the positive. An example of negative reinforcement is a student showing up late for class and the teacher not letting them in the classroom. So they're getting what they want by not doing that. Oftentimes kids with behavior struggles are acting out how they feel, which can be typical of kiddos that are involved in the system because they have so much going on that they don't always know how to say it. And so they may have an outburst in class and then get to leave class, which is what they really wanted to do anyways. And so that behavior is negatively reinforced. Positive reinforcement is always preferred over negative reinforcement. Because we want to hear about the positive things we're doing. We don't always want to hear about the negative, and we don't want to always reinforce the negative. It's more beneficial to reinforce the positive than the negative, and children and youth respond better to positive reinforcement. The key here is also consistency. And so every time that Johnny does something positive, we need to reinforce that. If we can't do it consistently, at least at the beginning consistently, and then weaning down. That's part of the role of the CASA, is that they see that somebody's there consistently, even if the caseworker leaves, if their foster parent changes, if their respondent parents are in and out, the CASA is consistently there, and that's a behavior that's positively reinforced, that they're going to continue to be there. And so we provide a lot of that as CASAs. And then there's punishment, which again isn't preferred over reinforcement, but positive punishment is adding extra chores or homework. And an example of negative punishment is taking away a child's video games after an undesirable behavior. Different parents have different parenting styles, and especially kids, if they are removed from the home or their parents are really struggling with parent skills, may need some support, from the caseworker, from their own therapist around how do we make the best responses to kiddos in the way that's going to support them. So another type of behavior therapy is called ABA, or Applied Behavioral Analysis. It's a type of therapy that can improve social communication and learning skills through positive reinforcements. So ABA is considered to be the gold standard treatment for children with autism spectrum disorder and other developmental concerns. Other examples of kind of behavior therapy, so there's motivational enhancement therapy, or what's called motivational interviewing. So it's a therapeutic approach used for defiant or resistant, quote unquote, clients who resist treatment for solving some of their behaviors. Oftentimes motivational interviewing is used with teenagers that come in and they're like, I'm fine, everything's fine, I don't need to talk about it. Or it could be used for a respondent parent that feels like there's no need to have social services involved in their life, everything's fine. Motivational interviewing can be used there. EMDR is a common therapy used with trauma. It stands for eye movement desensitization and reprocessing. It is recommended after people have kind of gained some stability, because what you're doing is reprocessing your trauma and making a different meaning of it and almost like putting it in a different part of your brain. So oftentimes individuals that are in the chaotic experience and in the trauma, it's not appropriate to do EMDR at that time. It is later after they've gained kind of some skills. So some of the kids may be appropriate for EMDR, some of them may not. That's a conversation to have with the therapist. Like, is this the right time to reprocess all of their trauma? Or do we need to wait until things are a little bit more stable in their environment and then do that? Exposure therapy is also another kind of behavior therapy. It's helped to overcome fears and life stressors for a calmer demeanor. So if kids are feeling really fearful of going back to a home, for example, you build up almost a ladder of tolerance. So we talk about what it would be like, and then we talk about the coping skills of what we would do there. And then we walk to the door of where we're going to go. And then we talk about the skills, and you kind of build a ladder up. And then we go inside the home together and use those skills. And so exposure over time. That can also be used for parents that are having their own kind of traumatic experiences and fears, possibly around reunification as well. So psychoanalytic theory, that's kind of the classic talk therapy. So a therapist listening to a client talk and subsequently establishing a set of emotional and behavior patterns from which to work further. Depending on the age of the kiddo, it may be talk therapy, it may be some of the other types of therapy that we're going to talk about. Teenagers as well, and adults, it depends on the diagnosis and what's going on. And then another one is called rational emotive behavior therapy, which is kind of an action therapy. So how can we rationalize our emotions and behaviors and look at it from a more kind of logical standpoint? A big one I'm going to talk about that was the end of that section before I go to cognitive behavior. Questions or clarifiers about some of those kind of behavior therapies?
No, incredibly thorough. Thank you.
Okay. The next big category is called CBT, or cognitive behavior therapy. So in a nutshell, CBT, and I'm going to refer to it as CBT, proposes that if you change the way you think, you will in turn change the way you feel. I've seen a quote before too that says, change the way you think, change your world. It's all about perspective and kind of how we're relating to our thoughts. And then that changes how we relate to ourselves and our feeling. So CBT typically involves a therapist working with a client to manage some sort of specific and problematic behavior, habit, or emotion, which continues to take place. So I, am struggling with my thoughts, or I am continuing to go back to the substance, despite the fact that I know that's not the best choice. I'm continuing to punch my friends, even though I know later it's not the best choice. So you change your attitude and your behavior by focusing on the thoughts, images, beliefs, and attitude that are held. So those are your cognitive things going on in your head, and how those processes relate to how you behave. It is a model or theory that it's not the events that upset us, but the meanings we give them. So for some kids, one thing can happen that upsets them, whereas the other kid down in the classroom down the hall, that same event can happen and it doesn't have as much of a meaning. Parents are really involved with kiddos in particular around how we make meaning of things. COVID is a great example right now. For some kids, it's like, yay, I don't have to go to school and I don't have to deal with the bullies and XYZ. But for others, if they're, they hate it. They would rather be with their friends. So it's the meaning that we personally make of it. And sometimes that meaning isn't always helpful. you know, that person doesn't want to be my friend because they hate me because I'm this and I'm ugly and, you know, I don't have any friends, and then the meaning we make in our head. So it's a lot of fact checking. So what evidence do I have to support this thought? Is this thought true? Is this thought helpful? Really questioning our thoughts so that we can question, you know, then in turn how it makes us feel. And it's a really kind of structured kind of therapy. It's not where you just kind of go in and talk freely about whatever comes to your mind. It's really slowing down and examining those thoughts. So talking about the automatic thoughts. So the things that like, oh, I'm ugly, that comes automatically to me. Well, how can we question and slow that down so that we don't always believe that? Or, you know, especially kiddos that have struggled with abuse or neglect, it's all my fault. How can we question that? Is that really our fault? How does that belief system serve us? If it doesn't, can we start to let go of that? Or if my mom loved me more, it's because she doesn't love me. So how can we question that? Is it helpful to hold on to that? If not, can we practice letting go? So that's kind of CBT in a nutshell. Any questions about that one? Okay. So the next one is play therapy, which is commonly used with kiddos. They say around age 12, but it can be used with older kiddos depending on their developmental and emotional kind of maturity and intelligence. So it's a psychotherapeutic approach to explore kiddos. It says ages 3 to 12 is where I found, but their lives and freely expressed repressed thoughts and emotions through play. So obviously with kiddos that are younger, they don't always know how to say how they're feeling. Even adults don't know how to say how they're feeling at times. And so by their play, we can kind of get an idea of what's going on. Sand tray therapy is a common where they use like different little mini figurines. And if there is kind of, they're showing, you know, this person is attacking this person, what does that mean? Is that something that has been in their lives beforehand that they've seen, that they're mimicking? Does that mean that they feel kind of attacked in their world? And it kind of shows and gives a window to like, oh, tell me more about that. What's that like to see? And so therapists are specially trained in play therapy to pick up on those things. And it takes place in a safe, kind of comfortable playroom where very few rules or limits are imposed on the child, really encouraging free expression and allowing the therapist to observe kind of the child's choices of what toys they're picking up, how they're picking them up, if they ask for permission, if they don't, what they do with the toys. Do they destroy the toys? Do they sit there and they're not even sure what toys to choose? Decisions and play style. So that's all very indicative of what's going on for the child. This can also talk about attachment style as well, because if they have all of these choices and they don't know what to do, it can be kind of indicative of they may not have somebody in their life that's kind of guiding them in that way. Or if they destroy all of the toys, what does that say? What does that mean? So the goal of play therapy is to help children learn to express themselves in healthier ways, become more respectful and empathetic, and discover new and more positive ways to solve problems. So if they're playing with a sword and they're, you know, using sword fighting and they're talking about how that mimics, or you get into a conversation about how that mimics what goes on at home, well, how can we do this differently? And have those conversations. The therapist uses play and other creative activities to communicate with the child and observe how the child uses these activities to express thoughts and feelings that are not expressed in words. So there's two main approaches to play therapy. Non-directive, it's based on the principle that children can resolve their own issues given the right conditions and the freedom to play with limited instruction and supervision. So sometimes with non-directive, there may be the kid in the room by themselves and the therapist is watching outside from a glass window or on camera. Sometimes they do it where the parent and the child are interacting in the playroom together and the therapist is watching outside to see what those interactions. So that's non-directive. There's also directive, which uses more input from the therapist to, sometimes it can be seen to speed up the results. It's also really interesting when people give directives to the kiddos, how they react, especially if you go from non-directive to directive. Well, this was my playroom. this is where I expressed, and now, somebody's coming into my territory. So play therapists use both approaches depending on the circumstances and what's going on. And again, can involve parents. Respondent parents can also involve foster parents if they are another constant in the child's life. Any questions about play therapy?
I think I'm surprised you said that they use it with kids up to 12, but I've always seen it with younger kids.
Yeah, and it can be used with adolescents as well, depending again on their developmental age, and adults. If they are kind of stuck in their developmental trauma from a young child, it can be really therapeutic to have them kind of go into their inner child and express what they need to express that they may be doing in a maladaptive way.
Wow, how interesting. Cool.
So the next one is related. It's called child-parent psychotherapy. So this is a really specific type of intervention. So it's an intervention model for children ages 0 to 5 who have experienced at least one traumatic event and or are experiencing mental health, attachment, or behavior issues, including PTSD, so post-traumatic stress disorder. It's based on attachment theory, but also integrates other types of therapies, including developmental, trauma, social learning, cognitive behavioral that we talked about. Therapy sessions include the child and parent or primary caregiver. So the primary goal of this model is to support and strengthen the relationship between a child and his or her caregiver as a vehicle for restoring the child's functioning. So again, if we have secure attachment with our guardian, we feel more like we can do things and we're okay. If we don't have that, we don't feel okay inside, and then start to act out kind of how we're feeling. It also focuses on other factors that may affect the caregiver-child relationship. So again, if this parent is in and out, and how that impacts their attachment style. If the parent is struggling themselves with a substance, with their own mental health, bringing that into the therapy and really seeing how that impacts the child. The aim of this specific intervention is to help restore normal behavioral developmental functioning in the wake of trauma. It concentrates on restoring the attachment relationship. So again, feeling like we're okay because we have that person. These are kiddos 0 to 5. And so restoring those relationships that have been negatively impacted, establishing a sense of safety and trust, which is huge, within the child-parent relationship, and making meaning of the trauma. So how do we move forward? If the child is moving back in with the respondent parent, if they are being adopted, how do we make meaning of what happened and move forward? Another part of kind of child-parent psychotherapy, and this is more of a broad, can include family therapy for kiddos of any age. And so that can be led by the child's therapist, it could be led by the parent's therapist, or it could be led by a neutral therapist that doesn't work with either the child or the parent individually. And it's really giving a place for parents to communicate openly and kiddos to communicate openly in ways that maybe they haven't before. And it can bring a lot of anxiety for a lot of people because it's talking about things that maybe we haven't, but the therapist is there to help guide that conversation and be a neutral party to help moderate it as well. Family therapy can be intense for a lot of people, but it also can be really beneficial, especially to kind of almost like air out some of the dirty laundry, so to speak, and air out some of the things that we don't feel like we can otherwise talk about. Any questions on those ones before I move to the last, my favorite one? So dialectical behavior therapy, also known as DBT, is a personal favorite of mine. I am trained in DBT. So it provides clients with new skills to manage painful emotions and decrease conflict in relationships. So it was actually started, her name is Marsha Linehan. She struggles with borderline personality disorder. She's a well-known behavior theorist, and DBT started with those that struggle with borderline personality disorder, then kind of moved to other personality disorders, and is almost like a gold standard for those that are really struggling to manage impulsivity in their emotions. So it specifically focuses on providing 4 different skill areas, and they build on each other. So the first one is mindfulness. So focuses on improving an individual's ability to accept and be present in the current moment. The second one is called distress tolerance. They did these I wrote them out of order. Let me go back to the order. So the second one is interpersonal effectiveness. So it consists of techniques that allow a person to communicate with others in a way that is assertive, not aggressive, assertive, maintains self-respect, and strengthens relationships. So kids and parents alike, anybody could use those skills. The third one is called emotion regulation. So it talks about strategies to manage and change intense emotions that are causing problems. So I'm feeling this really intense emotion and I want to act on it. What else can I do? Distress tolerance is geared toward increasing a person's tolerance of negative emotion and how they can manage it rather than trying to escape from it. Distress tolerance skills are really the crux of like, I'm in this moment and I want to do this. What else can I do right now to manage this instead of acting out on it, instead of, screaming at my teacher, instead of, being physically abusive towards my child? How can I manage that? So DBT skills are to have the capacity and to help those who want to improve their ability to regulate their emotions, tolerate upsetting events and negative emotion, to be mindful and present in the moment, and how to communicate and interact with others. So it talks, the D in DBT talks about dialects, so balancing the opposites. So that again can be, it's either, for some people it's either black or white, it's this or that. How do we live in the gray? How can it be both ands? So these again are very skill based. DBT is a shoot off of cognitive behavior therapy, CBT. So the therapist works a lot at how can it be both ands? How can I promote balance and not the all or nothing? So I lost my kids, there's no point in trying anymore. Well, how can it be, yes, I did, and I want to work towards getting them back. For kiddos, well, they don't like me, there's no point. Well, how can we work on mending that relationship? So again, it's a both and rather than an either or. The dialect at the heart of DBT, so the two that we're always keeping in mind, acceptance and change. So how can we accept what's going on and work towards change of the things that we can control and are within our vicinity to control? DBT is used a lot with adolescents. It's used a lot with adults. Lots of DBT groups that are kind of in the area. And is a really, really useful, I'm obviously partial because it's my favorite, but a very useful modality. And I think those are all. I don't know if there are questions about any of those or other things that have come up over time.
You have been incredibly thorough. Thank you so much for giving us an insight into this very, very complicated topic at times. But this is really going to help. I thank you so much.
Yeah, of course.